Good evening, everyone. I'm Dr. Vidhya Vasini, medical oncologist at Omega Hospitals, Hyderabad. Today, I'll be presenting 4 abstracts on ER-positive breast cancer. So, the first of these abstracts is the updated analysis from Paloma 3 trial, the overall survival with palbociclib plus fulvestrant in women with HR-positive, HER2-negative advanced breast cancers, presented by Dr. Christoph Nally at ASCO 2021. So, we know that Paloma 3 trial established the role of palbociclib plus fulvestrant in patients with hormone receptor positive, HER2 negative breast cancers who progressed on prior endocrine therapy. These results were first presented in 2015 ASCO meeting, which showed that palbociclib significantly improved the progression-free survival compared to fulvestrant alone. In 2018, with a median follow-up of 44.8 months, the protocol-specified OS analysis was presented, which showed a non-significant trend towards improved overall survival with palbociclib added to fulvestrant. In the current analysis, updated OS data with a median follow-up of 73.3 months was presented. The study design included patients with HR-positive, HER2-negative metastatic breast cancer who progressed after endocrine therapy or up to 1 line of chemotherapy for the advanced breast cancer. They were randomized in a 2:1 fashion to palbociclib plus fulvestrant versus placebo plus fulvestrant till progressive disease, toxicity, or study withdrawal. Stratification was by presence of visceral metastasis, sensitivity to prior endocrine therapy, and menopausal status. The primary endpoint was investigator-assessed PFS. Secondary endpoints were overall response rate, clinical benefit rate, OS, and patient-reported outcomes and safety. The results demonstrated a significant OS benefit with palbociclib when added to fulvestrant compared to fulvestrant alone. The median overall survival was 34.8 months with palbociclib compared to 28 months with placebo. And this represents a statistically significant 19% reduction in the relative risk of death with the addition of palbociclib. The 5-year overall survival rates were 23.3% in the palbociclib arm, whereas it was 16.8 months, 8% in the placebo arm. Hence, the overall survival analysis favored palbociclib across patient subgroups defined by the menopausal status, performance status, and site of metastatic disease at study entry. So, in conclusion, the final results from the Paloma 3 trial support the sustained and clinically meaningful survival benefits of palbociclib when added to fulvestrant across a range of patients with hormone receptor positive, HER2 negative advanced breast cancers that progressed on prior endocrine therapy. And this clinically meaningful improvement in overall survival was maintained with more than 6 patients who had progressed on prior endocrine therapy. So, the previous analysis, which was presented in 2018, did not show a significant improvement in overall survival. But the longer follow-up data now shows a significant improvement in the OS, showing the importance of following up these patients for a longer period of time to achieve the benefits. And these OS benefits were observed in multiple subgroups, including the intent to treat population, those who were sensitive to previous hormonal therapy, those who did not receive prior chemotherapy, patients with the non-visceral sites of metastatic disease, patients who were postmenopausal at study entry, and whose disease-free interval was more than 24 months. Favorable overall survival was observed in most subgroups, except among patients who were endocrine resistant or had prior chemotherapy for their advanced breast disease. And it was noteworthy that patients who had previous chemotherapy for their advanced disease, there was no difference between palbociclib and placebo in the overall survival. The investigators also evaluated the overall survival by tumor mutation status, showing a consistent survival benefit with palbociclib irrespective of the molecular signature. In this accord, around 330 patients who consented for a biomarker subgroup analysis were evaluated with their plasma, and the circulating tumor DNA was analyzed for the ESR1, PIK3CA, and TP53 gene mutation status. And it was observed that relative to wild type, each of these mutations was associated with worse prognosis in these advanced breast cancers. But the addition of palbociclib showed benefit in all these patients. So the take-home message from this abstract is, with more than 6 years of follow-up in the Paloma-3 trial, the addition of palbociclib to fulvestrant maintained a significant survival benefit compared with fulvestrant alone in patients with hormone receptor positive, HER2 negative advanced breast cancer that progressed on prior endocrine therapy. Coming to the second abstract for today, this is the phase 3 randomized control trial, the PEARL trial, which is palbociclib in combination with endocrine therapy versus capecitabine in hormone receptor positive, HER2 negative aromatase inhibitor resistant metastatic breast cancer. So we now know that CDK4/6 inhibitor in combination with endocrine therapy is the standard of care treatment for both newly diagnosed and previously treated patients with hormone receptor positive, HER2 negative MBC. And the most commonly used chemotherapy regime in these patients with demonstrated efficacy and safety is capecitabine. But to date, there is no direct comparison of CDK4/6 inhibitor plus endocrine therapy combination with capecitabine in the setting of disease progression on an AI. So the current study aims to compare the efficacy of palbociclib plus endocrine therapy versus capecitabine in 2 cohorts of postmenopausal women who have progressed on AI therapy. Cohort 1 included treatment arms with palbociclib plus exemestane as the endocrine therapy versus capecitabine, and cohort 2 had palbociclib plus fulvestrant as the endocrine therapy versus capecitabine. The cohort 2 was added based on reports of ESR1 mutations as the key mechanism of resistance to AI therapy in metastatic breast cancer, and that fulvestrant appears to be active against these ESR mutation positive tumors. So coming to the study design, patients with hormone receptor positive, HER2 negative MBC who had recurrence within 12 months or on adjuvant AI, or who progressed on or within 1 month of aromatase inhibitor therapy for advanced disease, or who progressed or who received less than up to 1 line of chemotherapy for their metastatic disease with no previous use of capecitabine, exemestane, or fulvestrant for their metastatic disease were included. And their ESR1 mutation analysis was done before treatment initiation. Cohort 2 recruitment was done during March 2014 to September 2016, whereas patients in cohort 2 were recruited from May 2016 to July 2018. And the treatment was until disease progression or symptomatic deterioration, toxicity, death, or withdrawal of consent. The co-primary objectives of this study were in cohort 1 and cohort 2 to compare the PFS with palbociclib plus endocrine therapy versus capecitabine in patients with ESR1 wild-type tumors, and to compare the progression-free survival in cohort 2 patients regardless of the ESR1 mutation status. The secondary objectives included PFS with palbociclib plus endocrine therapy versus capecitabine in all patients regardless of the ESR1 mutation status. Secondary objectives also included overall survival, objective response rate, clinical benefit, and response duration. Safety tolerability was one of the secondary objectives. Health-related quality of life and biomarkers were also considered. Coming to the results, the 2 co-primary endpoints were not met. The PFS with palbociclib plus fulvestrant was not superior to capecitabine in patients with metastatic breast cancer who were resistant to AI. There was no difference in the PFS either in the cohort 2 or in the cohort 1 with ESR1 wild type tumors, or in cohort 1 and 2 irrespective of the ESR1 mutation. So palbociclib plus endocrine therapy was not superior to capecitabine in patients with ESR1 wild type tumors also. And coming to the secondary objectives, there was no significant difference in the objective response rate or clinical benefit rate between palbociclib plus endocrine therapy versus capecitabine. So the conclusions of the study were palbociclib plus fulvestrant demonstrated similar PFS to capecitabine, and palbociclib plus endocrine therapy demonstrated similar PFS in women with ESR1 wild type tumors. And there was no difference in the efficacy comparisons in the subgroup analysis. But improved safety profile was observed in patients with palbociclib plus endocrine therapy when compared to capecitabine in terms of fewer treatment discontinuations and fewer treatment-related serious adverse events. And it is worth noting that compared with capecitabine, palbociclib plus endocrine therapy was associated with a significant delay in the quality of life deterioration. There was less treatment discontinuations due to the adverse events and a lower proportion of patients with related serious adverse events. So the findings in the Pearl trial indirectly suggest that palbociclib combinations are less effective in pre-treated metastatic breast cancer patients and should be used earlier in the treatment timeline, while capecitabine can be left for later lines. And capecitabine, albeit having higher adverse events, remains an appropriate alternative where healthcare costs are restricted and the CDK4/6 inhibitors cannot be used, because it is seen that single agent fulvestrant has lesser efficacy when compared to the combination of fulvestrant plus CDK4/6 inhibitors. And the efficacy results of the Pearl study were consistent across patient subgroups, except for the small proportion of patients with genetically defined non-luminal tumors. And the number of patients in this subgroup was very small, and caution should be exercised before coming to the conclusions in this results. And these results reflect the efficacy of palbociclib, which may not be the same as the other CDK4/6 inhibitors. It is seen that the newer CDK4/6 inhibitors have better responses in when compared to palbociclib in terms of endocrine resistant tumors. So in conclusion, palbociclib plus endocrine therapy did not improve progression-free survival compared to capecitabine in patients with aromatase inhibitor resistant metastatic breast cancer. However, it was better tolerated and showed improved quality of life. So the third abstract for this evening is the final results of the presented by Martin Miguel. So the final study also shows that there was no statistically significant difference in the overall survival and the PFS2 between the two arms. And so it did not meet its secondary endpoints of overall survival. So there was no overall survival benefit. Coming to the last abstract, this is the Padawan Trial, which evaluated early initiation of fulvestrant based on the ESR1 mutation emergence. So we know that ESR mutations, they restore the ligand-independent estrogen receptor activity, and they drive the resistance to aromatase inhibitors, but retain sensitivity to fulvestrant. They can be detectable in blood by cell-free DNA analysis, and their occurrence is rare at de novo metastatic disease, and they are frequently observed in patients who progress on first-line AI. So the concept of Padawan is to prevent or delay the tumor progression in patients receiving first-line AI by targeting the ESR1 mutation with a switch to fulvestrant as soon as this mutation is detected. So it was done in a three-step process. Initially, patients, around 1,000 patients were included in step 1. All of them were in first-line MBC, who are aromatase inhibitor sensitive, and the ESR1 mutation levels were monitored at inclusion at 1 month and then every 2 monthly. And patients who had rising blood ESR1 mutation levels with no synchronous progressive disease, they were included in step 2 and then randomized to continuation of AI or switching to fulvestrant before clinical progression. So the primary endpoint was safety, and investigator assessed PFS in step 2. And it was observed that in patients who were switched to fulvestrant even with the first appearance of the mutation had an improved progression-free survival of 11.9 months versus 5.7 months for patients who continued on AI upon emergence of the ESR1 mutation, with a delta of 6.2 months in the progression-free survival. And patients who were shifted or crossed over to fulvestrant upon progression had a median progression-free survival of 3.5 months, which was less than the progression-free survival when the switch was made earlier on in the course of treatment. So the conclusions of this Padawan trial is it was the first clinical trial to demonstrate the utility of ESR1 mutation monitoring, and it helps in optimizing the endocrine therapy partner. And upon ESR1 mutation detection, the median PFS was doubled by the switch from AI to fulvestrant therapy with no new safety signals. And this observed clinical benefit might be underpinned by the lower burden of these mutated tumor cells at the earlier initiation of fulvestrant, and it might not be catched up by standard fulvestrant based second line therapy, and it justifies the implementation of the Padawan treatment strategy as a valid option in the routine care, which is dubbed as a 1.5th line of treatment rather than the second line. So monitoring the rise of resistance associated mutations opens up new opportunities for cancer therapy, including newer agents and newer clinical settings like beyond the ESR1 mutations. But the limitations of this study include the investigations were not blinded for the treatment arm, and also the ddPCR assay used is not certified for clinical use in many countries. So the take-home message from the Padawan trial is the tracking of ESR1 mutations might be a valid option in patients treated with CDK4/6 inhibitors plus AI as the first-line therapy, and switch to fulvestrant at the detection of ESR1 mutations with an improved PFS. Thank you.